This is where we left off, right? Why is Cinderella bad at basketball? Why is Cinderella bad at basketball? Because she always runs away from the ball. Fair. What do you get when you cross a caterpillar and a parrot? A what? A carrot? I like that better. A walkie-talkie. What did the cat say after their friend asked them to speak up? The cat after their friend said speak up. Can you hear me meow? No? Okay. All right. All right, we are not sponsored by any cell phone company, so you can not like that one. That's fine. All right. As we finish out nervous system disorders, we're going to talk a little bit about acute brain trauma and insult to the brain. And we've got a couple of different types. So we either have what we refer to as blunt trauma, or we have open trauma. Right now, open trauma is a little bit more unusual. It's not as common. Obviously, the cranial cap would be open like during surgery, or if there was trauma and the skull cap was like disrupted, now you have an open trauma situation. But far more often than not, it's blunt force trauma to the head. Okay, athletics, even in trauma cases or accidents, car accidents, motor vehicle accidents, motorcycle accidents, biking accidents, athletics. We're going to talk here in a second about a case study that I hinted at on Tuesday from the coroner's office here in Coconino County. But before we get there, I want to talk a little bit about coup versus contra coup injury. So a head injury, straight up, is a coup injury under the site of impact. So someone falls and hits their head, okay? A baseball is thrown and it hits, or a softball, or soccer players go up for headers and their heads collide. This is real stuff. Pugilists, boxers, MMA, mixed martial arts. You have individuals that present who are intoxicated, stumbling around, they fall and they hit their head. Okay, these are all just real life things. A motorized scooter's cruising, an electric scooter's cruising down the pedway and runs into a pedestrian. I mean, I just made that one up. I'm sure it never happens. So that's just a standard coup injury. Contra coup is when the brain in the cranial cap that's floating in cerebrospinal fluid, that brain actually moves forward with the strike, right? And as that brain smacks the inside of the skull, there's a recoil, like physics. For every force, there's an equal and opposite force. It recoils and it goes the other direction, calling it a contra coup injury in the opposite side. So it's not uncommon in these cases, you have a coup injury, head strikes, there's a contra coup injury on the posterior aspect where the frontal lobe impact. So coup versus contra coup. Does that make sense? So these are things that would be investigated either under imaging if the patient hasn't expired, or if it's an expired patient, then obviously you can do autopsy and you can investigate. So in the autopsy investigation, this was a real case here in Coconino County. This is Bio 408. It's a fieldwork class. I have nothing to do with it. But a lot of my students end up looking into this. And they do sort of an internship and get course credit through the coroner's office. And then oftentimes when they let me know, I try to pay attention to some of the cool case studies that are relevant to what we're doing and get permission to present them like we are today. So 20-year-old Caucasian female tourist who's on antidepressants, Zoloft, falls and hits the back of her head. This is actually on 89A. This is going down from Flagstaff down to Sedona on those like twisties. And there was one area that they had pulled off to kind of look at the view, and she slipped. She expired on her way to the ED up here in Flagstaff. They rushed her to Flagstaff. They were closer to Flag than they were to Sedona. And the idea was she was presenting with pre-death seizure activity, and they didn't know if it was a brain injury, a brain trauma, or if the seizures are what took her. The Zoloft is obviously important, just so that you know what medication she's on. She wasn't inebriated. It was the middle of the day. There may be some other clinical issues that are happening. Maybe she took a little too much of the Zoloft. It made her dizzy. I don't know. Maybe it was on an empty stomach. Maybe she was nauseous. I don't know. Maybe it was a combination of that, and the road down to Sedona is pretty windy. Maybe it was that. Nobody really knows did they pull off because she was nauseous. They pulled over and she got out of the car and fell. So in the case study, the autopsy revealed significant occipital lobe trauma. So that's here. Possible hemorrhage and a hematoma with a contracute trauma to the frontal lobe. So the cause of death was determined to be brain trauma-induced death. So what struck first? What's that? Occipital lobe. She slipped and fell and hit the back of her head. And it was so aggressive that the brain rebounded against gravity and came up and hit the inside of the frontal lobe. That's a pretty serious fall. Okay? So there was significant trauma to the brain, so they determined that, that was the slip and fall, and that was the cause of death. Make sense? All right. So let's talk about diffuse injury versus focal brain injury. So global injury is kind of like what we just talked about, right? We just talked about traumatic brain injury in this 20-year-old Caucasian female. Diffuse injury is injury where you actually have axonal injury, diffuse axonal injury. There may be zero blunt force trauma. This is usually like a acceleration or a deceleration injury or a rotation type of injury. So you can see these pictures here, normal axon on the left image. Shearing of the axon, you can see the arrow indicating that the axons are being sheared. And the result is death of this central nervous system nerve as you kind of shear off that axon. So where you see these take place, unfortunately, is the disruption of these connections that could result in coma. One of the more common places that you see this is in shaken baby syndrome, where you have, unfortunately, parents that are exasperated and they don't know what to do, and so they just kind of very young nervous system, not as robust, right, as you and I, and so out of desperation they're kind of like, stop crying, right, and the head kind of does this because they don't have a lot of head and neck strength, and that causes a lot of rotational injury in the brain where you can have shearing. And this usually is pretty diffuse across the entire brain. Okay, the second one is focal brain injury, which is where we're going to dig into, and that's going to kind of where we're going to be for a while, for the remainder of most of today. So focal is grossly observable, like in our case study. You either have a contusion, a concussion, some type of hemorrhage, or a hemorrhage is like a active bleeding, or a hematoma, which is a bruise. It's blood that flowed and now it's clotted. So these are things that we observed in the last 408, Bio 408 case study that we looked at. So we're going to kind of unpack concussions right now, and then we're going to talk about CTE, which is chronic traumatic encephalopathy. We'll talk about that at the end of the lecture. So that's kind of a special case in the category of concussions. And then contusions, where you have an active lesion, and then we'll get into hematomas, which is like a bruise or a clot in the brain, and then active bleeding or hemorrhage. So this is what we're going to walk through. So what's a concussion? How many of you think you've had a concussion? Show of hands. Okay. Pretty common. How do they happen? Football? Yeah. Football? Baseball? Huh? Car accident? Ice skating? Yeah. Volleyball? A lot of sports? Automobiles, right? We poll the audience in 5 years, it'll be electric scooters. Okay. All kidding aside, I mean, these can be pretty serious. Concussions can be very serious. But typically, it's reversible. And so we don't take them that serious because they're reversible. But we're going to talk about repetitive concussions as time moves on in the semester, or in the lecture, today. So here you have no active contusion. A contusion is where you have a lesion, an identifiable lesion of the brain. So in a concussion, there's no lesion. So and there's no bleeding. There's no bruising. You've just stunned the brain. You literally smack the brain and stun it, right? So, and you know that if you flick nerves, if you mechanically agitate a nerve or stimulate a nerve, it'll fire, right? Think about reflexes, right? That little hammer that they hit you and then, you kick the physician, right? So if you mechanically excite a nerve, you'll fire an action potential. So a contusion is you've just stunned the whole thing, and it's kind of like in this monster contraction, or it's in a monster refractory period for a period of time. You tend to have amnesia or loss of memory, short-term memory. A lot of folks that have a concussion are like, what happened? I actually don't remember. I went up for the ball. The next thing I knew, I was on a stretcher, and coaches were looking down at me. No idea what happened. So you've lost all that memory of what took place. And the questions are, do you know where you are? What's your name? What's your address? How old are you? What's your jersey number? Right? All that kind of stuff. The pathogenesis is really unknown. I mean, the best that we understand is you've mechanically stimulated a ton of nerves all at the same time. And it doesn't make any sense. It's not in an organized fashion. Oh, sorry. It's not in an organized fashion. And so I forgot to silence my phone. It's not in organized fashion, so it doesn't make any logical sense. And so your brain just doesn't know what to do with it, and it kind of forgets the whole incident. If we look at the causes of concussion in children, pediatric cases, vast majority of them are due to falls. Okay, you're past that age, so now it's due to athletics, right, or car accidents, those kinds of things. As you get into geriatric medicine, more and more of those concussions will be falls as well. The good news is your center of gravity is usually your hips. And so when an older patient falls, usually the first thing that touches the ground is the hip. Okay, so it protects the brain. Bad news is we break hips. Okay, and that can be another comorbidity that's not so great for older patients. But in children, a fall, now about 45% of the concussions are by falls. So in a concussion, we have no damage to the brain parenchyma. There's no contusion to the brain parenchyma. In contrast with a contusion, you're going to see lesions within the brain, and you see some examples over here in the left hemisphere of this particular patient on autopsy, where you're seeing lacerations, or you'll see necrosis What kind of necrosis would we expect here? Liquefaction necrosis. You might see some bruising, which bruising is now in the area of a hematoma, right? So if you see a little bit of bruising, and these categories aren't like, oh, it's only a concussion, because Keller said that there's no bruising or lacerations. Could a patient have a contusion and have concussed as well? Yeah, 100%. Could they have a hematoma, bruising, with parenchymal brain tissue damaged and be concussed, like all three of these? Yes. So we're just kind of categorizing the different labels, but I don't want, they're not mutually exclusive. Does that make sense? They're not like it's just this, like, oh, no, doctor, that can't be a hematoma because the patient's concussed. They're gonna be like, yeah, I mean, I don't know who taught you that, but so don't walk away thinking you can only have one of these circumstances. But generally, the way we categorize these, like you can see in this lower left, a tremendous amount of clotted blood sitting on the brain in that image. And the brain is, the posterior aspect is to your right. You can see there's cerebellum in the lower right corner, and the individual is looking to your left, and the frontal lobe is to the left of the slide. And so you can see there on the left hemisphere, part of the frontal lobe, a smaller area of the frontal lobe, and a much larger area of the parietal lobe, there's evidence of clot or hematoma. Localized accumulation of blood. Another name for it is a bruise. Bruising of the brain is the way that you would hear that. Brain bleed, that's hemorrhage. We'll talk about that next. A brain bleed is a hemorrhage. But a bruising on the brain, that would be a hematoma. So we've got three different types. We've got epidural, subdural, and subarachnoid. And they're just defined essentially by the area that you have the clot. So if you look at this section up top, the left side of this is designating an epidural hematoma, and it's just above the dural meninges, the dura mater. And you can see on the right side, it's illustrating, and so that's what this one is, right? This is an epidural. This would be a subdural where it's actually beneath the dural layer and trapped, if you will. And then subarachnoid in the subarachnoid space. And in the subarachnoid space, which you see here, we typically see that with some sort of contusion because it's going deeper into the brain tissue. Subarachnoid space is more deep rather than superficial, so there's usually some contusion that takes place. It is possible to have, an epidural hematoma without a contusion and the patient's concussed. And so if you had a concussion and you were kind of dizzy and not feeling well, like a couple of days later, you probably got imaging and they're looking for clots. That's what they're looking for. And they're going to look for lacerations too, but you'd have to hit your head really darn hard for a laceration. But for a brain bleed, that clotted, and they can tell if it's an active bleed or if it's a clot. And the severity of pain it elevates when you start having clotted blood there. So cross section of the brain here. This is an intracerebral hemorrhage, which is bleeding inside of the brain itself. And this is the picture of the subarachnoid hemorrhage in the subarachnoid space. Right. You could confirm subarachnoid hemorrhage. How? How could you easily confirm that? Cerebrospinal fluid. You do a spinal tap, grab CSF, and if you have red blood cells in there, then there's an active bleed into the CSF. All right, the hemorrhage. This is a rupture of the vessel with an active bleed. Most oftentimes, this is due to hypertension, high blood pressure. Usually, these are aneurysms that are going to form. So an aneurysm is a defect in the vessel wall when it's pressurized, if you have a hypertensive individual and they have vascular disease, so the vascular disease makes the blood vessel weaker. Hypertension, they have high blood pressure. The pressure inside the vessel is higher. So if you have a weak vessel, higher pressure, you're going to get a bulging of the vessel wall. So I equate this to, if anybody grew up and you know, back in the day, I'm sure it's like so bad for you. We used to drink out of the garden hose, right? You just play in the front yard, the backyard. You get tired, thirsty, and you know you don't want to go all the way into the house and get a glass of water, so you just turn on the spigot, right? Well, if it had one of those nozzle things on it, and you turned it on and left it on, if it was an old hose that sat out in the yard and the casing started to get old, you could see like a little bulge happen out of the garden hose. That's an aneurysm. That little pocket that's, you know, bulging is what we're talking about here. So this is the circle of Willis, and you can see, you know, the prevalence of these aneurysms based upon the neurovascular anatomy, where we have, you know, 40% of these aneurysms happen right here at this bifurcation with the anterior communicating artery. So high blood pressure, there are genetic defects in patients that lead to what we call AV malformations or arterial venous fistula malformations. Not the main cause, but it does happen. Those patients can be younger, but generally speaking, an aneurysm of the neurovascular anatomy is something that elderly patients experience. Because you kind of have to have two things. You have to typically be hypertensive or have high blood pressure, and you have a weak vessel wall. If it's a saccular aneurysm, that's these that are drawn here. They look like a sac, right? And the saccular aneurysms are weak spots. The other way you could get an aneurysm is called a fusiform aneurysm, where you have the vessel and it's equally bulged on both sides. Those are less prone to rupture because you're distributing the pressure amongst a larger surface area, but with a saccular, it's like a troubled spot, and that's the place that it's weak. That's where the balloon's going to pop. Trauma with contusion can nick a vessel or traumatize the vessel. So you could have an aneurysm that forms post-trauma. But what will happen in any of these circumstances where you have a rupture, whether it's an aneurysm that ruptures, which is the most common, or trauma with contusion that causes a rupture of one of the vessels, is you get an active bleed. This is a picture of a saccular aneurysm that blew out, that ruptured. And this is the result that leads to a hematoma, where you just have a tremendous amount of blood in the you know, cerebral space. So after it dies off in pressure, the pressure subsides, you're going to get a clot. So these saccular aneurysms, so up here is that same picture from that previous slide. At the level of a circle of Willis, this is a saccular aneurysm that's ruptured. This is histology of a saccular aneurysm. And so this ginormous, like, gourd-looking structure, it looks like a gourd, true to fall nomenclature. We'll talk about pumpkins and, you know, squash and gourds. So this one, the diameter should mimic this one. So you can see how it comes in and then just kind of blows out. Same thing here. This is hematox lineus, and this is the vessel here going up into the brain. This is the vessel coming up from the neck, and this ginormous pocket. You can see some clot in the aneurysm itself right here, but this whole pouch is the aneurysm. This vessel should kind of just continue straight up here without this giant left aneurysm. So just a few saccular aneurysm pictures for you. Okay, other brain disorders that we're going to cover. First up is going to be meningitis. Meningitis is an infection of the leptomeninges. Leptomeninges are sort of, to remind you, the combined space that's occupied by the pia mater as well as the arachnoid mater. The causal agents here the etiological agents, these could be either bacterial, fungal, or viral. And the symptoms, the clinical sequelae, are headache, photophobia, or like aversion to light, neck stiffness, as well as patient irritability. These people kind of get grumpy. And you're like, you're not really acting like yourself. They actually have an active infection of the brain. How does that stuff get there? Into the leptomeninges. How does it get there? Bacteria, fungus, or viruses? It's in the spinal fluid. So it crosses through the blood-brain barrier, the ependymal cells in the ventricle, right, that line the ventricular system. There's some weakness, and a virus, a bacteria, or a fungus can make its way through. So you would confirm, same question, how would you confirm meningitis? Spinal tap, pull cerebral spinal fluid, take a look at it, culture it, determine if it's bacterial, fungal, or viral, because the treatment modality to the patient needs to be an antifungal, an antibacterial, or an antimicrobial, antibiotic, or an antiviral. If you leave it untreated, it's not good. Patients die from meningitis. They get pretty bad, in pretty bad shape real quick. You can see at the base of the skull this active infection, right? You have pus, purulent discharge on the base of the skull. Obviously, this patient passed away from meningitis. That's how you got that picture in your textbook, right? So the lumbar puncture, you're going to see lower levels of glucose. You'll see evidence of infection. You'll see leukocytes in the area. You'll see elevated protein and lower sugar, because these infection agents are using the sugar to make energy. That's why people get irritable. Is the infection is competing for the glucose, which is the main source of fuel that the brain runs on. So they basically get hangry, right? If you know anybody that suffers from hangry episodes, right? I mean, it's not a clinical term, but it kind of is, right? We all know what we're talking about. Streptococcal pneumoniae and Neisseria meningitis. So these are two of the more common bacterial infections. The college age, like in this room, you're most likely going to be susceptible to Neisseria meningitis. Whereas the very young and the very old, so our geriatric and our pediatric patients, usually present with a streptococcal pneumonia infection. How do I remember that, Keller? Like, well, remember strep throat? Those of you that had strep throat, it was more likely when you were a kid. Streptococcal pneumonia is the same infection for strep throat. And now that you're in college and you get into middle age, you probably won't have strep throat for the rest of your life. You're just sort of like done with that phase. So that's streptococcal pneumonia when you were a kid. And then just think the old people have the same challenges as young people. And then in college or in the military, like the Neisseria meningitis likes to populate in crowded spaces. So like dorm rooms, dorm facilities, as well as like military barracks. So if you have meningital infections or outbreaks that happen in the military, it's usually in barracks, military barracks. So this pyogenic meningitis infection picture, you can see the active pus that's coming out, that's oozing out. It's actually pretty gross. Okay, so continuing on. CJD, Creutzfeldt-Jakob disease. It's a really fun term to say, Creutzfeldt-Jakob. So this is a disease that's very similar. Has anybody heard of Creutzfeldt-Jakob? Okay, a few. Anybody heard of mad cow disease? Okay, also a few. Very similar diseases. So this is a mutated prion disease. So prions are fragments or components of normal cellular proteins. And the prions get mutated and can actually form a mutate. So you can see up here on the right, you've got nomenclature of PRPC, which is a normal prion, and then a PRPSC, which is a mutated form of a prion. And those mutated forms can be through transmission or inoculation. So it's an infection. So if you have contaminated meat that you eat, and prions are very small, so they can cross the blood-brain barrier. So if you have a food supply that had a mad cow disease, or what is called a bovine spongiform encephalitis, the meat's contaminated with these aggregate prions. Those aggregated prions, or those mutated prions, can cross the blood-brain border, cause a conformational change in humans with normal prions, and lead to aggregation of these prions in the cerebrum, and it causes large vacuoles. It basically reorganizes the nervous system to hollow it out. And as it hollowed out, it has like this spongy look. So you can kind of see mutated prions on the lower left in the brown stain where you're seeing them aggregate. And on the right slide in hematoxylin and eosin, you're seeing some open white spaces. And in the inset in the upper right corner is a blow up diagram of a vacuole. And so this is the spongiform manifestation of the disease, which leads to a lot of dementia. And that's why in cows, they start acting crazy. And in humans, they become demented and act crazy too. So you get the cytoplasmic vacuoles, and you destroy a lot of the cerebral tissue, or the parenchymal tissue in the brain. Creutzfeldt-Jakob, not a good disease. And so you'll see this on occasion with like the FDA or USDA will inspect facilities. You might see like a 60-minute special or kind of a 2020 special on sanitary conditions of butchering, whatever, fill in the blank, right? You watch one of these things and you're going to walk away going like, I'm going to be vegan, no more. Okay, I'm done with this. It gets pretty aggressive. So the biggest challenge, like in the meat industry, is there's not a lot of margin from a business standpoint, so they're always trying to figure out ways to do things efficiently. Makes sense. Well, and this is going to be hard for maybe some of you to hear, but it's not uncommon for slaughterhouses as they lead the cattle down a chute, and the most humane way that they've come up with it, but it's very simple, is they basically punch a hole in their head with like a rod device that they're in a chute, they can't move any direction, and I was like, duck. You always want to yell duck, right? Like, because all they got to do is like do this, but they're probably restricted too, where they can't really do that. But they have these like mallets that come in and pop holes in their head. Well, if they have a mad cow disease, then it's just kind of everywhere. And as they capture the meat, the ground meat, like ground meat is just sort of meat that is sort of extra meat that doesn't go into like ribeye or filet mignon or back straps or ribs or all your favorite cuts of meat. So the ground is just kind of the leftover scraps, and then they grind it up, and then they make burgers out of it, right? So you really want to be safe, go with the more expensive cuts of meat. Okay, the ground is usually where the problem is, but that's how it transfers from animal to human. Okay, it's a lot more common. Hang on, Joe. It's a lot more common outside of the United States. And a lot of the issues that we've known about in modern era have been OUS issues. In the meat availability in the United States is actually quite good. I will say that. The most recent outbreak that I'm aware of was in the UK, and then there was also one in Brazil. And so the meat industry here is very tightly controlled. And I think also part of it is it's not as crowded. There's a lot more space for cattle in the United States. You just have a little bit more open space. Question?
How do you treat prions?
How do you what?
How do you treat prions?
How do you treat prion disease? I don't know of a treatment for prion disease as soon as it's at this level. Probably medically manage. Yeah, the challenge with prions is they are very, very small. They're very tiny. So they cross over the brain barrier, the blood-brain barrier readily. Okay, MS, multiple sclerosis. So demyelinating, autoimmune disease, what type of hypersensitivity? 3, 4, what do you remember? 4, 3, I see 3, 4, 4, 3. This is a hypersensitivity type 4 because it involves T cells. If you look at this picture, you can see the CD8 positive T cells here, these cytotoxic T cells. All right, remember that's sort of our defining characteristic of hypersensitivity 4, type 4. So oligodendrocytes, right? These are the cells, and the Schwann cell is the counterpart in the periphery. But same kind of issue happens. Is you've got the periphery on this side, you've got the CNS on this side. You start developing these antibodies that target the myelin that the oligodendrocyte or the Schwann cell has made. You recruit cytotoxic T cells to destroy the myelin, and it leads to plaques or fibrous scarring. So now the action potential that used to go via saltatory conduction or kind of hopping from node of Ranvier to another actually has to go through continuous conduction, which is much, much slower, if you recall back from 201. And so an order of magnitude slower in speed. The etiology that we talk about, we've got a number of details associated with this. So women are unfortunately twice as often as men to be having episodes of MS. The incident rate is about 1 in 1,000 people in the United States. The issue associated with the clinical symptoms are kind of a steady decline in function. And there's episodes or times where it can go into remission and then it can be activated. Stress can facilitate further deterioration because glucocorticoids that are released during stress suppress the immune system. And so now the immune system that's already reacting towards you is sort of compromised. It creates a loss of motor and as well as sensory function in these nerves, because it's not just motor neurons that are myelinated, some sensory neurons are myelinated as well. This brain image here on the lower left, you've got plaque that's found here around the lateral horn of the ventricle. So this plaque, here's the ventricle, and this is white matter, and this red stuff, there's no such thing as red matter. You guys never learned about that, right? So here you've got the white matter, the gray matter, and this red architecture is the plaque that's pretty aggressive in this MS patient. There's some theories about inheritance. MS patients inherit certain genes from mom and dad. This is an autoreactivity where you've got a leaky immune system, so you have self-reactive clones that are reacting towards the myelin. Questions? Okay, for this one, I'm going to show a quick video that I have queued up. And this is on the YouTube site. I'll pause it quite a bit. So this is a Supreme Court. Oh, you can't. This is not a Supreme Court justice. Hang on. This is an old video that I got from a colleague when he was earlier in his career. He would come do a guest lecture. His name is Dr. Miller. He's actually a neighbor of mine. We've known each other a long time. But he taught at medical school, and he taught a lot of neurophysiology disorders in med school. And so this was a video that he provided to me, and this is an older Supreme Court justice. If this video will play.
You ask me why should I? With this experience. When I first came here, I had no experience whatever. Qualified me to address the issues that this court is required to address inside. And now, after doing it for 30 years, I have much more confidence in my judgment than I did then.
So I want you to kind of pay attention.
More than 80 years old. As far as he's concerned, and most would agree, his mind at this advanced age is as sharp as ever.
Supreme Court justice, he's over 80 years of age. You can listen to him talk. He's totally with it. All right. So the question is, why does Alzheimer's affect some patients and not others? Right? Is it an age, old timers disease is the the common phrase that's used for Alzheimer's? Yeah, it tends to affect elderly patients, but not every single one. Right? We're not going to watch this whole video, but I want to pose that question to you. And this is another video of an individual who had a twin brother. One has Alzheimer's that you're going to hear from, and the other doesn't. Again, same genetics. It's like, wait a second, what's going on here? So this is sort of our control patient, right? Supreme Court Justice Brenner.
Is as sharp as ever. This man is almost exactly the same age. But last year, he started having problems with names, including his own. Tonight, he will forget how to return home. And tomorrow, he may no longer recognize his wife.
What it's called?
No, I'm almost. I could take a little time.
I'll give you a hint. Begins with an H. Sounds right.
It's frustrating to
I know.
Yeah.
It's a heart.
For one, the future ended forever last year. For the other, each new year seems an improvement over the last.
Okay.
The positive change with age, as the 17th century Dutch master Rembrandt observed in himself, begins long before old age. For the artist, the gathering maturity might have been no more than a passage of being, the grave impress of time. Today, Rembrandt students and modern scientists may share two beliefs. In old age, creativity need not diminish, and wisdom may flourish. Before our eyes, Rembrandt's technique grows in subtlety. Vanities fade. And within this life passage is evoked the fermentation of experience, the encumbrance of self-doubt. From these brushstrokes of self emerges Rembrandt's particular wisdom, punctuated just before death by the master's final offering, the unforgiving statement of who he is and how he had come to be.
Wisdom for me.
Okay, so I'll let you watch this. If you continue to watch this, you'll see more displays from Hugh. Let's see if I can find. Okay, so there's more discussion here about Chief Justice. There's an explanation, and then there's more interviews of that's actually, I believe this is Hugh's brother. No, this is Hugh. Okay, so you get more explanations of Hugh. This is his brother Bert. Okay, twins. One presented with Alzheimer's, one did not. And in this video, as this plays out, the interviewer kind of points out, like, well, Hugh is obviously quite intelligent because it can play off their forgetfulness. And I think there's one incident where, like, there's a brush or a comb, and he's like, I can't tell you exactly what it is right now, but I mean, you know what it is, right? Like, he's playing with the interviewer, like kind of toying with the interviewer a little bit, like clever, kind of, almost boyish like. So the question that comes there is, as patients age with Alzheimer's, their educational level, we'll talk about this, their educational level may play a role in how quickly you see symptoms. Not necessarily an indication of the progression of the disease, but more of an indication of, can they hide it with loved ones? Because as you start realizing that deterioration, as individuals start realizing it's embarrassing, it's frustrating. So stuff for you to think about for later, and stuff that you can watch if you would like to dig into it a little bit more. But what is Alzheimer's? It's not called old timers. That's what you hear because everyone thinks that it's only old people, or it's associated with the elderly. Well, there's a higher propensity for Alzheimer's in older patients. Okay, but now we have early onset of Alzheimer's. We have other dementias. This is just one of many different types of dementias. And I see a shirt from Barrow Neurological Institute where I have a number of colleagues. Next week we're getting into cancer. We'll talk about glioblastomas. We'll talk about cancer. At Barrow, a lot of what they treat is either cancer or dementias. A lot of the patients that they interact with. So just the most common type of dementia, and only about 10% of these dementias are thought to be hereditary as of now. But some risk factors associated with Alzheimer's: age. The older the patient, the more susceptible they are to developing a dementia. So it's considered to be a disease of the age or the elderly. But that's not a hard and fast rule. Also, prior head trauma has a lot to do with it. So back to the concussion discussion. Repetitive concussions are not a good thing. And that's what a lot of, trainers and coaches will advocate for their athletes. Prior head trauma. Female gender. Females tend to be more susceptible to it than men. And I think that gap is closing now. It's closing with heart disease and it's closing with Alzheimer's. A low education level or a low level of mental exercise. The thought process, there's two arguments here. One is it if you don't use it, you lose it? So if you don't exercise your brain, you're not, you're done using your mind, you're not doing Sudokus, you're not trying to stay mentally sharp. Are you getting closer and closer to a dementia? The other theory of thought is what I sort of explained with Hugh, is the higher educated the patient or the more they use their brain, a lot of times it's a little easier for them to, I can't figure out, what is this? What is this structure? Well, you use it up here. Can't remember it's a comb or a brush, but it's kind of playing with the interviewer, trying to trick them to think, did they really forget the term, or are they just having fun here with this interview? They're kind of a cute old man, and he's just kind of playing around with me right now, right? Toying with me. It's a mind game. This is a plaque disease. So what you're seeing here up top, you get what's called amyloidosis. So you get these beta amyloid plaques, and those are the extracellular lesions. Those are the lesions that happen outside of the neuron. And then intracellularly, inside the neuron, you have these neurofibrillary tangles. And so you get plaques that happen outside and tangles that happen inside. And so what you're looking at up top is this transmembrane protein, this red cylinder with the yellow cylinder that's intracellular. And you get these cleavage sites that take place. Some of them that aggregate outside and form the plaques, others that aggregate inside and form the neurofibrillary tangles. So it first appears as impacting higher order brain function. The brainstem isn't necessarily impacted. It's more of the frontal cortex, or the midbrain, the memory centers, the hippocampus, the amygdala, the emotional centers, the cingulate gyrus. Their personality can change if it's in the frontal cortex. They start behaving a little funny. They forget where they live. They don't remember their spouse. You heard they don't remember their loved ones, which is really tough on families. In the histology down at the bottom, we've got a couple of different captions here. So on the far left, these are plaques. These are amyloid plaques that are being highlighted in sort of this dark brown stain, amyloid plaques. And then in the middle picture is an antibody. So this is an immunohistochemistry against the alpha beta peptide that's at the core of the plaque. And so the alpha beta peptide at the core of the plaque are these aggregates right here. And those are those circular patterns. And you can see if this is in the frontal cortex and you're getting all these plaques, wherever those plaques start showing up, you're going to lose neuronal function in that particular area. And then the last one, these are tangles. And these tangles are immunohistochemistry for tau protein that helps stabilize the microtubules. So all of the brown is inside of the neuron, and these are these neurofibrillary tangles that are highlighting the tau protein of the microtubules within the neuron itself. Another nervous system disorder that became very popular. So the individual that sort of popularized Parkinson's disease was Muhammad Ali, the boxer. Donated a tremendous amount of money to Barrow Neurological Institute, and so they have a Parkinson's center at Barrow. And I was a big Muhammad Ali fan. My mother passed away from cancer, and she had a brain lesion. We'll talk about it next week. And so we spent a lot of time years ago at the end of her life just trying to get treatment at Barrow, and they were fantastic. So that's when I got this picture in front of this Muhammad Ali banner as they were kind of expanding the facility. But Parkinson's disease is a disease that affects the substantia nigra. And so you can see a normal pigmented brain on the left, and you can see a depigmented substantial nigra where you've lost a lot of the ability to make dopamine. And so when you lose your ability to manufacture dopamine in the brain at the level of the substantia nigra, this dopamine typically mitigates or blocks unwanted movements. And so as we do our day-to-day activity, and you pick up your pointer, you pick up your toothbrush, and you do all these things, everything's really smooth. And with Parkinson's patients, there's a tremor. And so they'll go to pick up, their toothbrush, and they'll have a tremor. And these unwanted movements make for jerky type of clinical sequela because you've lost the ability in the midbrain, part of the basal ganglia, specifically that substantial nigra, to manufacture dopamine at normal levels. So Parkinson's disease most often develops after the age of 50, most often. It's the most common nervous system disorder of the elderly in this classification of tremor-like activities. Kind of similar to Alzheimer's is the biggest category of dementia. Parkinson's is the biggest category of tremor type of activity. The passing of Muhammad Ali was in 2016, which is the same year my mother passed, and that's when this was breaking ground, and why you see this picture from about 9 years ago. So there'll be some diminished facial expression in patients, a stooped posture, slowness of voluntary motion, so they kind of just behave more slowly, shortened, accelerated gait, rigidity, and the underlying essential tremor. All right, CTE. CTE. This is chronic traumatic encephalopathy. We talked about this at concussion at the beginning when we talked about concussion. Said I was going to come back to it. This is one of the reasons that we've been learning now that repetitive head injury is a bad thing. Not only does it make you more likely to have a dementia as you get older, but chronic traumatic encephalopathy has been highlighted in professional football players as well as in professional boxers. So there was a sort of a theory on Muhammad Ali there's no question he had Parkinson's disease, but was the Parkinson's essentially exaggerated or triggered by chronic traumatic encephalopathy. So this is repetitive head trauma. Progressive degenerative disease in patients with repeated concussions or traumatic injuries. And it was thought to only be in boxing population. But very recent present, and there's a movie on this, and I'm going to show you the trailer, it came to light that football players were struggling with this. And struggling with it to the sense of erratic behavior. They were doing some crazy kind of almost like criminal activities that you're like, what's wrong with, like rage, just like they became a very different person. So you get the same problem, tau protein accumulation over time, which is what you see in Alzheimer's. The tau protein of the microtubules of the intracellular neurofibrillary tangles that we just talked about. So there is a lot of overlap with some of these nervous system disorders, and that's scarring that's taking place that's blocking normal neuronal function. Memory loss, impulsive erratic behavior, impaired judgment, aggression, depression, balance issues, and the onset of dementia. So the next movie, the next video that I want to show you is, anybody like Will Smith? I actually think he's a fantastic actor. So, and if you don't really know much about him, you could watch. I'm not trying to think of a funny movie that he did. He's a very versatile actor, but he plays Dr. Bennett Amalu in this particular movie, who's a Nigerian American physician, and he pulls off the accent, which is kind of crazy. He's a forensic pathologist and a neuropathologist who was the first to discover and publish CTE off of autopsies. These were U.S. football players. And, this was actually first described, CTE was first described in the 1920s. And it was described in the 1920s in a pugilist community, which is a boxing community, by Dr. Harrison Martland. And he referred to it in his publication as punch drunk syndrome. So these boxers behaved as if they were punch drunk, even though they weren't in a boxing match, which is kind of wild. Okay, so this is a trailer for a movie appropriately referred to as Concussion. Oop.
When I was a boy, heaven was here, and America was here. You could be anything, you could do anything. I
the wrong person to have discovered this.
If you don't speak for them, who will?
I forgot to mention, it is based on a true story.
I found a disease that no one has ever seen. Repetitive head trauma chokes the brain. The NFL does not want to come here. You turned on the lights and gave their biggest boogeyman a name. You're going to war with a corporation that owns a day of the week. No proof was presented today.
I think they own 3 days now.
They have to listen to us. This is bigger than they are. What you think they're doing to you now? That's nothing. You have no idea how bad this could get. I have to keep going. They want you to say you made it all up. If they continue to deny my work, men continue to die.
That's an old movie. It's out.
You're asked to leave it alone. But sometimes you can't. Who are you? Truth. Tell the truth.
Okay. You're like, wow, we're getting all sorts of movie recommendations. It's a great flick. I mean, I love these because when you get scientifically accurate movies like entertainment, I feel like it's almost like it counts as study. Okay. So CTE, normal brain on the left, advanced CT on the right. This is the stuff that Amalu discovered and reported. That's actually real. Now, it's been Hollywoodized, but Amalu was a real physician. And a lot of times, they wouldn't take him serious in the medical community, probably for two reasons. One, he wasn't an American. And the other one is because he was a black physician. And so it's kind of interesting to see how it plays out in this movie. I think they do a really good job, and I thought Will Smith just nailed the role. But this is a real issue. And now you play soccer, volleyball, football, high school stuff, and you've had a couple of head injuries. Not good. But we're talking about professional football players, which is they've had like 30 years of head trauma. You know what I mean? Kind of a big deal. Punch-drunk syndrome was later characterized not as CTE, but as dementia pugilistica. Dementia of the boxer is what it translates to. So that wraps up nervous system disorders. Any questions before we say farewell for the week? I'm off to my daughter's soccer game. Hopefully no